Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
Hello, my name is Sam Klempner. I'm a GI medical oncologist at Mass General Brigham in Boston, and welcome to this program called HER2 Evolution in Gastroesophageal Cancers, New Therapies and Optimized Outcomes. This is a big topic, so we're going to spend a little bit of time talking about sort of all aspects of HER2, ranging from biology, diagnostics, and then, of course, therapeutics, and how we think about some of these agents in gastric and GE junction cancers. Just to take a step back to thinking about, all of our cancer biology in medical school and fellowship, HER2 is a normal transmembrane receptor tyrosine kinase with an extracellular domain, an intracellular signaling domain, and a transmembrane domain, often called ERBB2 by gene name, but more commonly referred to as HER2. There are other HER family genes. HER1 is actually EGFR, and then HER3 is the heterodimer for HER2, and then there's also a HER4 isoform. We know that heterodimerization, so HER2, HER3, and homodimerization, so two HER2 molecules can actually associate, and that dimerization leads to autophosphorylation of the intracellular component and then activation of the downstream signaling cascade shown here on the right. The most common intracellular signaling pathways that are activated by extracellular ligand binding or overexpression in the setting of genomic amplification are both the RAS-RAF MAP kinase pathway as well as the PI3-AKT-mTOR pathway. The net effect of this is driving features and programs associated with malignant transformation, features that enable metastasis, proliferation, growth, invasiveness, etc. And HER2 is, of course, a well-classified oncogenic feature across multiple tumors, but we'll be focusing in gastric and GE junction cancers. There are some features that have been associated with higher rates of HER2 positivity. If you look across large survey-type series or landscape-type papers, such as the TCGA and the ACRG, you'll see a range anywhere from 12 to 27% of gastroesophageal adenocarcinomas have HER2 amplification and similar proportions with HER2 overexpression. And commonly, amplification does lead to protein overexpression as well. So those two things are correlated. We do know that more proximal tumors, so GE junction and cardia cancers, are much more likely to have HER2 positivity than distal tumors. We also know this is much more common in intestinal types, and intestinal type also tends to be chromosomally unstable, so those two things themselves are linked. Hence, we see it more commonly in chromosomally unstable tumors, which is CIN, versus the genomically stable tumors. Interestingly enough, There are some biologic patterns of metastasis in HER2 positive tumors, such as higher propensity to spread to the lung, liver, and actually lymph nodes as well. If any gastric and esophageal cancers go to the brain, it's more commonly the HER2 positive patients. There are multiple studies looking at the optimal cutoff and the diagnostic criteria for calling something HER2 positive. The ASCO-CAP guideline is the broadly adopted one. I'll just walk you through it quickly. So if you were to divide this slide in half, the left side, 3+ and 2+ FISH positive, those are positive. The right side of this slide is considered negative. So if you're IHC 1+ or 0, that is considered negative, and we don't do any further testing per the standard guidance. This is important because this is different than things like breast cancer, where we're seeing HER2 low and HER2 ultra low being potentially distinct diagnostic entities and associated with activity for TDXD, for example. We don't have the same level of evidence or spectrum in gastric and esophageal cancers. So a 3+ refers to strong and complete basolateral membranous activity in more than 10% of tumor cells. And that's highlighted by an example in the bottom left. In those cases, you're done. If you see that on a pathology report, that patient is considered HER2 positive. If you see an IHC 2+ report, that patient is not considered positive or negative until you have the FISH assay to be the tiebreaker. So you see in the bottom IHC 2+ histological example, and then you see if someone has amplification genomically by FISH, then that patient would be considered positive if the ratio is greater than 2.0. So 3+ positive, 2+ FISH positive, both considered HER2 positive. You can see that there is guidance about resection specimen or primary or metastatic site. This is really in acknowledgement of the extensive intra and intertumoral heterogeneity that is seen for really all the biomarkers in gastric and esophageal cancers. Ideally, this would be studied in multiple biopsy specimens when feasible. And the reason is that you can see exactly what is highlighted in the arrows. This would be an example of a tissue sample, and you can see that there's clear regions. If you were focused just in the red, you would call this area 3+, and that would be positive. However, a broader look at the tumor as a whole, you can see that there are clearly regions of tumor that have no HER2 expression. And this is why, in a perfect world, we have multiple samples, 6 to 8, or surgical resection specimens. You do see that, when we're stuck, and sometimes we can use FNA. NGS and ctDNA are considered complementary modalities and have some concordance with IHC. So this can move up your confidence. For example, if someone is 2+, FISH ratio is 2.2, technically that patient is HER2 positive, but if you saw a high level of amplification by ctDNA or NGS, you might actually feel even more confident about the clinical decision or probability of benefit from trastuzumab or other HER2-directed therapies. This is sort of the standard NCCN and global breakdown about available agents for HER2 positive patients, focusing a little on the first line throughout the remainder of this talk, but second line and later is highlighted on the right. We know trastuzumab, in addition to doublet chemotherapy, improves survival in HER2 positive patients. We also know, as I'll touch on a little bit later, that in people who are double positive, so HER2 positive and PD-L1 positive, the addition of pembrolizumab on top of trastuzumab and doublet chemotherapy also improves survival further based on KEYNOTE-811 trial. In the second line and later, we now have substantial data for trastuzumab deruxtecan. This is endorsed on multiple guidelines, and this is based on some of the Destiny Gastric studies, DG01, DG02, and DG04. And then in China, there is this disitamab vedotin, another antibody drug conjugate, which has also shown substantial activity and is approved after 2 prior systemic therapies. We're going to focus a little bit on the first line. There are a few different mechanisms of action On the far left is the typical monoclonal antibody like trastuzumab, which binds to a particular extracellular domain epitope, as shown in the graphic. The primary mechanisms here in naked antibodies is recruitment of immune cells and FC-mediated antibody drug cellular cytotoxicity. The antibody drug conjugates, of course, many of them bind to the same epitope as trastuzumab, but not always. They are essentially using the HER2 more as a landing zone to deliver the payload, which is cytotoxic chemotherapy, topo-1 payload, or a microtubule inhibitor are the two most common types of payloads. And this is really more of a very clever way of delivering chemotherapy. And then bispecific antibodies like zanidatamab and bebtelovimab actually can bind multiple epitopes on HER2, and these also recruit ADCC and inhibit intracellular signaling. So the totality effect is inhibition and ultimately a combination of direct cell death from cytotoxicity as well as immune-mediated death from ADCC. The TOGA trial was really the benchmark and what established HER2-directed therapy as an option in frontline patients. Here you're seeing the data in 3+ or 2+ FISH positive, and you can see that the addition of trastuzumab in this subset improved the overall survival from about 12 months to 16 months. So that is a hazard ratio of 0.65. And this is what led to both the ASCO-CAP diagnostic sort of cut points for HER2 definition and also the wide adoption of trastuzumab for HER2. So now we test everybody, and this is the benchmark. KEYNOTE-811 is a modern phase 3 trial that really asked a very important clinical question, which was, in light of all the data for immune therapy in stage 4 disease, could we not add immune therapy on top of TOGA, essentially? There's also some preclinical rationale to suggest that when you use antibodies like trastuzumab, you may mediate some PD-L1 upregulation in response to the ADCC mechanism, which I showed a little bit earlier, supporting a combination rationale. So that's exactly what this trial did, randomized people 1-to-1 to essentially TOGA as the control, or TOGA plus pembrolizumab as the experimental arm, and you can see the dual primary endpoints of overall and progression-free survival. What you can see here is two curves that separate quite nicely. This is, again, patients in our dual positive, so HER2 and PD-L1 positive. You can see both an extension of the median overall survival from about 16 to 20 months, as well as a nice tail of the curve in the pembrolizumab-containing arm with improvements in 2- and 3-year survival rates. From a progression-free survival standpoint, you can see almost 3.5-month improvement in progression-free survival, and also a similar shape to the curve with almost a 20% 3-year progression-free survival rates. This is just a reminder that HER2 is a little bit different disease than HER2 negative. 20% 3-year progression-free survival rate is significantly better than we get for HER2 negative disease with chemo and IO or chemotherapy alone. So this is clearly somewhat of a different biological subgroup for which we have active therapies like trastuzumab, or in this case, trastuzumab plus pembrolizumab. Zanidatamab is a very promising newer agent, and we have seen phase 2 data, and we're all very eagerly awaiting the phase 3 data, which has the potential to change practice. This is a single-arm phase 2 in HER2 positive patients, focusing a little bit more on part 2. This is the traditional positive population, 3+ or 2+ and FISH positive. No prior HER2-directed therapy, so this is a frontline population. And here you can see the options for chemo, CAPOX or FOLFOX, or potentially cis-5FU with zanidatamab. One thing we did learn is that there are significant rates of GI side effects, like there can be from many of our other chemotherapy combinations as well. And antidiarrheal prophylaxis was added to help reduce this. The primary endpoint of this trial was investigator-assessed objective response rate. and you see the secondary endpoints listed over there on the right. As you see this data, keep in mind the data that I showed you for Keynote 811, as well as the TOGA data for PFS and OS. First of all, very encouraging response rates. Centrally confirmed HER2 positive patients, you see a response rate of 84%. That is among the highest response rates we've seen with any of our trial data. This is in comparison to about the 72% response rate we saw for Keynote 811 in those double positive patients. Again, you see a durable progression-free and overall survival here with a median progression-free survival of over a year. And in the centrally confirmed population, about 15 months. So again, if you take a really quick flashback to this data that I showed you, this is again a phase 3 trial with more numbers, but you can see the median PFS here in the experimental arm is around 11 months. And here you see it at 15 months. So a very encouraging signal. Similarly, overall survival of 3 years, roughly in the centrally confirmed population. So this drug does come with some additional side effects, which are primarily GI, primarily diarrhea. And you can see that antidiarrheal prophylaxis is effective. So it went from about 56% grade 3, and grade 3 is impacting for patients, down to about a quarter of patients with grade 3 after the antidiarrheal prophylaxis. So meaningful improvement clinically for sure. The Destiny Gastric 03 is exploring another important question, which is, based on the activity of trastuzumab deruxtecan in the metastatic setting in the later line patients, like Destiny Gastric 04 and Destiny Gastric 01 and 02, those were primarily second and third line trials. Could we move this active drug into the front line? Again, you see that these are patients who are locally assessed HER2 positive by the standard definition, so 3+ or 2+ and FISH positive or FISH amplified. Any PD-L1, so not restricting to the PD-L1 positive like the Keynote 811 approval that I showed you before. And the two arms that I'll show you here are D and F, which is T-DXd at 2 different doses with 5-FU or capecitabine and pembrolizumab. So this is essentially a dose optimization of this regimen in a frontline population. And you see the response rate as the primary endpoint and PFS and OS as other endpoints. These are the waterfall plots for the two arms of Destiny Gastric 03. Take this with a caveat of median follow-up of 7 to 8 months, but we're talking about response rate here, so that shouldn't be as much of an influence. You look at the PFS, this matches Keynote 811 quite nicely in both these arms, suggesting that there's not a compromise in the PFS or response rate here. Interestingly enough, the response rate in the 5.4 milligram dosing is numerically higher. Again, these are a little bit smaller numbers, but I think a lot of us feel that the slightly lower dose of T-DXd and 5-FU in here, this may be the optimal dosing strategy to move forward in frontline combinations, but of course that remains to be ultimately decided. But the response rate of 73% is in line, if not a little bit better than what is seen in Keynote 811, suggesting this is an active combination. The toxicity was a little bit higher in the 6.4 milligram per kilogram dosing than in the 5.4 milligram dosing, with a grade 3 adverse event rate of 88% versus 47%, and a substantially lower discontinuation rate in the 5.4 milligram per kilogram dosing. Disitamab vedotin is another very encouraging drug. This is the agent that's approved in China in the later line setting. Can we move it to the earlier line setting? Again, you can see a similar population, frontline HER2 positive. Here, there is a couple different arms. You can see that there is a HER2 traditional positive, that's in blue, And there is a HER2 low cohort, similar to what's been done in breast cancer, as well as with TDXD in DGO1. You can see that this drug is combined with immunotherapy and chemotherapy. There is also a interesting, essentially chemo-free combination, the DV plus toripalimab and trastuzumab. Again, response rate being the primary endpoint here. And what you can see is very encouraging response rates. You can see right there in green is highlighted a chemo-free response rate. This does come with some grade 3-4 adverse events rates as noted. The median progression-free survival was not reached versus 14.1 months in the non-DV containing regimen. Not reached as in encouraging, similar to the zanidatamab. The confirmed in the HER2 low population does suggest some activity here. And this is a population that is not generally candidates for approved HER2 agents, but certainly an area that we're all actively exploring. There are multiple trials exploring these combinations in the front line, and I'll highlight a couple additional ones here. So the Horizon GEA, that's the zanidatamab trial that we're all sort of waiting to see the results of, hopefully relatively soon. There are 2 Chinese trials of disitamab vedotin based on the promising activity there. Destiny Gastric 05 is sort of the extension of 03, building on that regimen. And then Artemide Gastric is in a very interesting combination with a PD-1 TIGIT bispecific plus either TDXD containing arm or the rilvegostomig trastuzumab chemo arm. And so this is another large phase 3 that will help add a little more granularity along the lines of what to expect from HER2 in the frontline setting. What conclusions can we draw from this data? I think a few broad strokes. One, there are multiple active strategies to target HER2 in gastric and GE junction cancers. Patient selection remains important. We have yet to be able to reliably move these agents into lower cut points. So the definition of IHC 3+ and 2+ FISH positive remains the benchmark. And then there is an important aspect of toxicity management. Adding drugs on top of drugs can improve response rates and sometimes progression-free and overall survival, but it must be balanced against toxicity and side effects for our patients. Looking ahead, moving these agents even earlier in the disease setting into the non-metastatic disease, we saw some very encouraging data just a couple weeks ago at ESMO. This is taking standard of care FLOT chemotherapy and adding pembro and trastuzumab. So sort of like taking Keynote 811, but swapping the chemo for FLOT and putting it into localized and locally advanced patients. And the schema is shown here. And what you see is, again, there's a relationship between activity and PD-L1 expression, higher pathologic complete response rates in the PD-L1 high patients. Similarly, higher biomarker status, in this case HER2, translates to higher pathologic complete response. In the overall population, the pathologic complete response rate was 48%, so very encouraging. This is versus about 20% with FLOT plus durvalumab, for example. So laying the foundation for some very interesting non-metastatic trials. As I mentioned, treatment selection is very important. So these are sort of the typical side effects across the HER2 spectrum of drugs. Some of these side effects are more common with certain classes versus others. Diarrhea, as I mentioned, trastuzumab and zanidatamab. This is managed with typical antidiarrheals and sometimes can lead to discontinuation. Infusion-related reactions, zanidatamab and HER2 bispecifics can cause this. This is managed per institutional standards with pre-medications and adjustments to the infusion. Cardiotoxicity is relatively uncommon, but is a well-known side effect across HER2 drugs. This is why we institute routine echo monitoring for these patients. Hematologic toxicities are really only seen with the antibody drug conjugates, where we're talking about the cytotoxic moieties. And of course, this requires routine follow-up for hematologic toxicity, just like we'd be doing prior to chemo when these patients come in. And finally, it's important to be aware of the interstitial lung disease that can be seen with antibody drug conjugates and also can be seen with immune checkpoint inhibitors. So certainly diligence and education for patients about reporting symptoms, new cough, new shortness of breath, should prompt very quick evaluation with CT and sometimes involvement for our pulmonology colleagues. We talked a little bit about this, educating patients on toxicities, making sure that we're reliably assessing, involving the whole team, and instructing patients how to report symptoms. And of course, we should never ignore these symptoms. Few pointers on best practices for managing toxicities. I mean, I think everybody is a good oncologist and used to managing these types of things. I think attention to the pulmonary symptoms is very important. Sometimes this can prompt both a cardiac and a pulmonary workup. And then infusion reactions, of course, is really about close communication with everyone on the treatment team, infusion nursing, etc. As HER2 regimens become available, what key factors? I mean, this is really the biomarker definition. We haven't been able to move beyond the HER2 3+ and 2+ FISH positive. So it's really important to ensure that this happens. It's also important after trastuzumab to strongly consider repeat biopsy and reassessment for HER2 positivity after trastuzumab-based therapy in the front line. And this is actually suggested in the NCCN as well as the FDA labels. So in summary, we talked about a lot of stuff. I tried to cover a lot of ground. We need to test all these patients because we have good options. We have options in the front line as well as options in later line. We owe it to our patients really to try to stay on top of this data. There's a lot coming. The zanidatamab trial is something we've been waiting on and hope to see soon. Some of these other TDXD trials, as well as the Artemide trial, look quite interesting. And ultimately, all of this data will come together to guide the sequencing, which we don't have a lot of studies to formally examine sequencing. Certainly, we want to hear feedback, how I did. If there's other things you'd want to hear about, welcome all types of feedback. Thank you for everybody for your attention.